Melissa Chacona, Raleigh Police, keep your hands where I can see them.
What is this? I just arrived at work. What is...
This is Melissa Chacona, a surgical practice nurse in Raleigh, North Carolina. She had already been convicted once for stealing medication. Nobody checked. Nobody stopped her. And by the time anyone did, 78 vials had been hollowed out.
78 vials of fentanyl, morphine, and meperidine tampered with by replacing medication with saline for surgical patients.
I am a surgical nurse. I handle...
78 vials, less than 15% of the medication printed on each label. The rest, saline, drawn out, replaced, and slipped back onto the supply shelf of a Raleigh area surgical practice. By the time chemists at a federal laboratory finished testing them, the woman in this footage would be facing a federal drug tampering charge that the United States Attorney for the Eastern District of North Carolina would describe with one phrase: the patient's in the most vulnerable position imaginable. Real talk. Have you ever come out of anesthesia and just trusted that every milligram listed on your chart actually went into your IV? Tell me in the comments. And if you are new here, subscribe. We cover the medical accountability cases the mainstream news quietly walks past every single week. Melissa Elizabeth Chacona was born in 1977 in Greenville, North Carolina, the second of 3 children in a working-class household 20 minutes off Highway 264. Her father, Ronald Chacona, drove long-haul freight for a regional carrier based out of Rocky Mount, gone 4 nights a week and home only long enough to eat a hot meal and sleep in his own bed before the next dispatch. Her mother, Carolyn, worked the billing window at Pitt County Memorial Hospital, the same hospital where Melissa would be born, where she would have her tonsils taken out at 9, and where she would later complete the clinical hours of her associate's degree in nursing. Carolyn's job is the detail that mattered. Every weekday afternoon, Melissa and her older brother would walk from the school bus stop to the hospital lobby and wait the last hour of their mother's shift in the cafeteria, doing homework at a laminate table by the vending machines. By the time Melissa was 11, she could name every department on the hospital map. She knew which elevator went to maternity. She knew that the cafeteria coffee was free for staff after 4 o'clock. She knew the woman at the gift shop counter by name. She told her 6th grade teacher she wanted to be a nurse the way other kids said they wanted to be astronauts. Her grades were not exceptional. Her teachers used the words quiet, dependable, and easily overlooked in successive years of report cards. She finished J.H. Rose High School in 1995 in the middle third of her class and enrolled the same fall at Pitt Community College into the 2-year nursing program her mother had quietly suggested over Sunday dinners since Melissa was 13. She passed her NCLEX RN exam in May 1997 at age 20. Her first nursing job was on the medical surgical floor of a community hospital in Wilson, North Carolina, 35 miles west of Greenville. 12-hour shifts, 3 days a week, starting pay of $15.48 an hour. The unit handled post-operative recovery for general surgery, orthopedics, and gynecology. Her preceptor wrote in her 90-day evaluation that she was calm under pressure, technically careful, occasionally slow to ask for help. That last phrase appears in some form in every annual review she received for the next 20 years. She married a man named Daniel Whitlock in 1999, a regional manager for an auto parts supply company she had met at a friend's wedding in Goldsboro. They moved together to Fuquay-Varina in 2001, a small Wake County town south of Raleigh, where new subdivisions were going up on what had been tobacco fields 5 years earlier. Daniel took a promotion that involved travel 4 days a week. Melissa picked up part-time hours at a surgical recovery unit in Raleigh and finished her bachelor's of nursing in 2004 through a hybrid program at East Carolina University. They had no children. She would later tell a workplace co-worker, in a moment she could not have known was being remembered, that the 2 miscarriages she had between 2003 and 2005 were the worst things that ever happened to anyone in this town. And nobody knows about them but us. By 2008, she had been a registered nurse for 11 years. She held 3 certifications: basic life support, advanced cardiac life support, and a peri-anesthesia nursing certification she had pursued on her own time. She worked overtime willingly. She covered Christmas shifts. Co-workers described her as the one who never complained, and the one who would stay late if you asked her to. 2 separate annual reviews from that period use the same evaluation language: detail-oriented, reliable, demonstrates initiative. She had also, by 2008, begun taking Percocet for a back injury sustained while transferring a 280-pound post-surgical patient from a gurney to a recovery bed. The prescription was legitimate. The refills were legitimate. The dependency that followed was not legitimate exactly, but it was not yet criminal. That distinction would not last. The Raleigh area surgical practice, where Melissa Chacona worked in 2019, was the kind of operation that has become standard across American outpatient medicine. A multi-specialty group that performed roughly 40 to 60 same-day procedures per week, scheduling everything from carpal tunnel releases to vascular access placements to orthopedic arthroscopies. The practice maintained its own pre-operative bay, 2 operating suites, and a 6-bay recovery area. The public reporting did not name the practice. The federal indictment and subsequent DOJ press release referred to it only as a Raleigh area surgical practice. That anonymity was deliberate. It protected the patients who had passed through during the window of the tampering, and it protected the institution from a level of public attention that the documented facts could not survive intact. The narcotics it dispensed for surgical pain control were the standard kit. Fentanyl, a synthetic opioid roughly 100 times more potent than morphine, used in anesthesia for both induction and intraoperative pain management. Morphine, the oldest and most studied analgesic in the operating room, drawn most often in 5 milligram or 10 milligram vials, and meperidine, sold under the brand name Demerol, a synthetic opioid used in smaller doses, often for the management of post-anesthetic shivering, a known side effect of certain general anesthetics. Together, these 3 drugs constitute the core of perioperative pain control. A patient undergoing surgery at this practice, or at any practice like it, would receive some combination of all 3 during the course of a single procedure. These medications are controlled substances, Schedule IIs in the case of fentanyl and morphine. Their storage, dispensing, and disposal are governed by federal regulation, state pharmacy law, and the practice's own internal protocols. A typical surgical practice keeps controlled substances in a locked dispensing cabinet, increasingly an electronic system that requires a nurse's user code and a witness for every withdrawal. Vials are signed out by serial number. Used vials are returned. Unused medication is wasted in front of a second nurse, who signs the waste log alongside the dispensing nurse. That is the system as designed. What the system does not see, however, is what happens to a vial between dispensing and administration. A glass vial of injectable fentanyl looks identical to a glass vial of saline solution. The labels are nearly the same color. The contents are visually indistinguishable. Both are clear, colorless liquids. The rubber septum on the top of the vial, the disc that an anesthesiologist pierces with a syringe to draw out medication, will reseal after being punctured. With patience and a steady hand, a person trained in injection technique, For instance, a registered nurse with 20 years of experience can draw out the contents of a sealed vial and refill it with another clear liquid. And unless someone specifically holds the vial up to weigh it or test its chemical composition, the tampering is invisible. The trust framework, in other words, is the entire defense. Surgical pain medication is one of the few categories of medication a patient cannot evaluate, cannot advocate for, and cannot intelligently refuse, because it is administered while they are unconscious or only just emerging from anesthesia. The system assumes that the vial says what it says. It must assume that. There is no fallback if it cannot. That assumption was about to be tested at a Raleigh area surgical practice for 4 straight months. The first vial Melissa Chacona tampered with, as later established by lab analysis, cross-referenced with the practice's dispensing records, was a 5 milligram morphine vial drawn from inventory on the morning of January 14, 2019. The vial was logged as wasted later that day under protocol. According to the practice's records, a second nurse witnessed the disposal. What the witness did not see, because no one ever sees this, was that the vial had not been wasted. It had been emptied into a syringe Chacona had palmed in her left hand, capped, and slipped into the inside pocket of her scrub jacket before the witness ever arrived. The morphine in that syringe would be used that night by Melissa Chacona in her bathroom in Fuquay Varina. The empty vial would be refilled. This is the part of the case that no headline can convey in a single line. From a small bottle of bacteriostatic saline she had taken from the supply room 3 weeks earlier. Using a sterile syringe and a fresh needle, she drew up 5 milliliters of saline, injected it through the rubber septum into the empty morphine vial, withdrew the needle, and held the vial up to the fluorescent light of her kitchen to check the meniscus. It looked exactly like the vial had looked that morning at the practice. The label was untouched. The cap was intact. The rubber septum had one almost invisible puncture mark from the original draw, a mark that any vial of injectable medication accumulates simply by being used. She returned the vial to her purse. The next morning, she returned it to the supply room of the practice. This is the procedure, performed at scale, that the federal investigation would later catalog 78 times over the next 4 months. The escalation was steady, not dramatic. In January, she tampered with 7 vials, almost all of them morphine, the drug whose dosing schedule she knew best. In February, she added fentanyl. The fentanyl vials were smaller, 2 milliliter ampules, the kind drawn for induction during a single procedure, and the volume she extracted from each was correspondingly smaller. But fentanyl is roughly 100 times the potency of morphine. The same volume of extracted drug went much further. By the end of February, 21 vials had been compromised. In March, she added meperidine, Demerol, the third drug in the standard surgical analgesic kit. Meperidine vials are dispensed in larger volumes. The opportunity was correspondingly larger. By the end of March, the cumulative count was 46. The clinical effect of what she was doing, the actual medical consequence inside the operating rooms of the practice, is the part of this case that no one at the practice would understand until months later. Multiple anesthesiologists, drawing what they believed to be a 5 milligram dose of morphine from a vial labeled 5 milligrams of morphine, were in fact administering at most 3/4 of a milligram of morphine, dissolved in 4¼ milliliters of saline. The patient on the table, unconscious under general anesthesia, received less than 1/5 of the analgesic the chart said they had been given. Recovery nurses, observing patients waking up in more pain than expected, attributed the discrepancy to the patient's individual pain threshold, to anxiety, to the natural variability of human response. They remedicated. They drew more from the supply that had been tampered with. They sometimes administered 3 doses where one should have sufficed. Each dose, of course, also diluted. The signs that something was systemically wrong were there. The signs were dismissed. There were other signs as well. Chacona's co-workers noticed in the late spring of 2019 that she had begun to look unwell, pale, thinner, with the dry skin and constricted pupils that colleagues experienced in clinical care might have recognized as opioid-related. She missed 2 shifts in early April with what she described as a stomach flu. She fell asleep in a chair in the break room on her lunch hour on April 9th, and a nurse anesthetist found her there, slumped sideways, the cup of coffee in her hand cold and still half full. The nurse anesthetist asked if she was all right. She said yes. The nurse anesthetist did not file a report. The dispensing logs of the practice for April 2019, later subpoenaed by federal investigators, would show that Chacona signed for or witnessed the dispensing of 142 controlled substance vials that month, a figure roughly twice the rate of any other nurse on the practice's rotation, in a month where the practice's procedure schedule did not increase. Nobody flagged that. Nobody audited it. The numbers sat in a database, untouched, until investigators pulled them. By the end of April, the count of compromised vials had crossed 70. By the second week of May, the count was 78. By the third week of May, the practice had figured out that something was wrong. The trigger event for the investigation, as later reconstructed from internal practice records and the federal case file, was a single post-operative observation made by a recovery room nurse during the second week of May 2019. A patient who had undergone a routine outpatient procedure, the public reporting did not specify the procedure, was waking up in significantly more pain than the patient's intraoperative chart should have produced. The chart documented the administration of standard intraoperative analgesia. The patient was on the verge of tears. The recovery nurse, a woman who had been at the practice for 11 years, looked at the chart, looked at the patient, and did the one thing none of her colleagues had been willing to do up to that point. She pulled a fresh vial from the same lot. She looked at it under the medication room light. She did not see anything unusual. The label was intact. The seal was intact. The contents looked normal, clear, colorless. She brought it to the practice's clinical director and said, in the closest paraphrase the federal record contains, "I want this vial sent out for testing. Something is wrong with our morphine." The clinical director sent the vial out for testing. He also pulled 3 other vials from the same lot and sent those out as well. 48 hours later, the lab report came back. The vials contained saline, trace amounts of morphine, enough to register on a chromatograph, not enough to medicate a child. The clinical director looked at the report for a long time, and then he made 2 phone calls. The first was to the practice's general counsel. The second was to the FDA Office of Criminal Investigations. The FDA's Office of Criminal Investigations is the agency most people have never heard of and never expect to be investigated by. It exists to enforce federal law against tampering with drugs, medical devices, and food products. Its investigators are sworn federal agents. They carry guns. They wear plain clothes. They open files quietly, and the people they investigate often do not learn they are under investigation until the day the agents knock on the door. In Chacona's case, the agents took a different approach. They did not knock. They did not yet know who they were looking for. They knew only that a Raleigh area surgical practice had 4 lots of controlled substances that had been chemically compromised, and that the compromise pattern, extraction and saline replacement, executed with sterile technique discipline, indicated a perpetrator with clinical training and authorized access. The investigators pulled 3 months of dispensing records. They cross-referenced every withdrawal, every witness signature, every waste event timestamp against the practice's procedure schedule and staff roster. They built a matrix. They watched the matrix narrow. It narrowed to 1 nurse. They did not announce their conclusion. They began instead to pull every vial Chacona had ever signed for that was still in inventory. They sent each one to the lab. The lab results came back over the course of 4 weeks. Vial after vial, saline, saline, saline. The case was already complete by the time anyone said her name out loud. The investigation that the FDA Office of Criminal Investigations built against Melissa Chacona did not require a confession, an informant, or testimony from a single co-worker. It rested on physical and laboratory evidence, a body of proof so dense and so quantifiable that, when finally placed in front of a federal grand jury in the Eastern District of North Carolina, it produced an indictment in a matter of hours. The first pillar was the vials themselves, 78 glass vials of fentanyl, morphine, and meperidine, drawn from the inventory of a Raleigh area surgical practice between January and April 2019. Each one tested individually by a federal chemistry laboratory using high-performance liquid chromatography. Each one returning the same result, with minor variations, less than 15% of the active drug printed on the label. The remaining volume in each vial was bacteriostatic saline. The chromatograph traces, when laid side by side, were nearly identical, as though produced by a single hand using a single procedure repeated 78 times. Which, in fact, they had been. The second pillar was the sterility analysis. When the laboratory analyzed the vials for microbial contamination, a standard secondary test for compromised injectables, multiple vials returned positive cultures. The tampering procedure, performed in a bathroom in Fuquay Varina, rather than in a sterile pharmacy compounding hood, had introduced bacteria into the vials. The contaminant species identified in the laboratory report included 2 organisms found commonly on human skin and 1 organism associated with kitchen surfaces. The vials, as the lab report put it in the dry language of forensic chemistry, were no longer sterile. The third pillar was the dispensing record. The practice's electronic medication dispensing system had logged every withdrawal, every waste event, and every override Chacona had performed for the 4 years she had worked there. Federal investigators, with the cooperation of the practice's clinical director, mapped every controlled substance event against the practice's procedure schedule. The pattern that emerged was unambiguous. Chacona's withdrawals were not concentrated on the days she was actually administering medication during procedures. They were concentrated instead on the days she was assigned to inventory reconciliation, the role responsible for taking medication out of the cabinet, accounting for it on paper, and either administering it, transferring it, or wasting it. That role, by design, was the one role with the greatest unobserved access to vials between dispensing and return to inventory. The fourth pillar, the one that would, in the prosecutor's eyes, foreclose any defense premised on a single isolated incident, was Melissa Chacona's prior conviction. Several years earlier, in a state proceeding in North Carolina, she had been convicted of diverting medication from a previous nursing employer. The case had been handled at the state level. It had not cost her her license. The Board of Nursing had imposed a period of supervised practice and required participation in a substance abuse monitoring program. She had completed the program. She had been returned to full practice. She had been hired, with the conviction disclosed, by the Raleigh area surgical practice in question, and she had, within months of resuming unsupervised access to controlled substances, begun diverting again, at greater scale, with greater consequence, in a setting where the patient population was uniquely unable to detect what was happening. The system had been warned. The system had not acted. 78 vials had been hollowed out before anybody looked. The confrontation took place on a Tuesday morning in late May 2019 in the employee parking lot of the Raleigh area surgical practice at approximately 7:15 a.m. Chacona had just arrived for her shift. She was walking from her silver Honda Accord toward the staff entrance with a coffee cup in one hand and a tote bag in the other. Two federal agents, one from the FDA Office of Criminal Investigations, one from a partnering federal agency, were waiting near the door. They identified themselves. They asked her to step away from the building with them. She did, slowly, the coffee cup still in her hand, her face captured later in body-worn camera footage from one of the agents, drained of color so quickly that one of the agents reflexively asked if she was going to faint. She did not faint. She stood, instead, very still, looking at the agent's badges and saying nothing for a measurable interval before either agent spoke again. The lead agent asked if she knew why they were there. She did not answer. The agent told her, in the calm and clinical phrasing of federal investigators, that they had probable cause to believe she had been tampering with controlled substances at the practice, and that they had laboratory analysis of 78 vials of compromised medication. He told her she was being placed under arrest. She finally spoke. The transcript of the body-worn camera footage records her saying, in a voice barely above a whisper, "I know. You know what, ma'am? I know why you're here. I'm not going to say anything else without a lawyer. That's your right. Turn around for me, please." She turned. The coffee cup fell from her hand and burst on the asphalt. The agents handcuffed her at the wrists behind her back. Her tote bag, the printed staff schedule poking from its open top, was placed on the trunk of the nearest vehicle and photographed in evidence. She did not look back at the practice building. The federal grand jury for the Eastern District of North Carolina returned an indictment within weeks. The charge was tampering with a consumer product, a federal offense governed by Title 18 of the United States Code, originally enacted in the aftermath of the 1982 Tylenol poisoning cases in Chicago, and applied, in this case, to the 78 vials of injectable opioid medication that Melissa Chacona had hollowed out and refilled with saline between January and April 2019. The case was assigned to a senior federal prosecutor in the Eastern District. The defense was assigned to a court-appointed federal public defender, a veteran attorney with 2 decades of experience in federal drug cases. The motions practice in the months that followed was procedurally routine. There was no motion to suppress the laboratory evidence. There could not be. The vials were the case. The chromatograph traces were the case. There was nothing for the defense to challenge that did not concede the essential fact that the medication, a surgical practice in Raleigh, had believed it was administering to patients during the spring of 2019, had been, in 78 separate documented instances, mostly saline. On March 9, 2022, Melissa Elizabeth Chacona, then 44 years old, appeared before a United States magistrate judge in the federal courthouse in Raleigh and entered a plea of guilty to the federal tampering charge. The plea agreement, filed in open court that day, included two provisions of unusual specificity. First, she would surrender her North Carolina nursing license permanently. There would be no possibility of administrative reinstatement, no path to a hardship reissuance, no future return to practice in any state that honored the North Carolina Compact. Second, she would be subject to a federal sentence at the discretion of the district court, within the statutory range of the tampering offense. We are heading into the sentencing now. If you have made it this far, you already know this channel covers cases that other channels do not. Subscribe if you have not. There is more to come on this one. And the judge's words at sentencing are the part of the record I cannot stop thinking about. Sentencing was set for May 22nd, 2023. The hearing was held in the same federal courthouse in Raleigh where she had entered her plea 14 months earlier. The United States Attorney for the Eastern District of North Carolina, Michael Easley, attended personally, a signal in federal practice that the case mattered to the office institutionally and not merely as one case file among many. The prosecutor's sentencing memorandum walked the court through the 78 vials, the chromatograph results, the sterility findings, and the prior state diversion conviction. It walked the court through what those vials had meant in the operating rooms of the practice during the months of the tampering. It walked the court through the specific clinical reality that a surgical patient cannot evaluate the medication being administered during anesthesia, that the patient is, in the prosecutor's exact phrasing borrowed later for public comment, in the most vulnerable position imaginable. The defense presented a sentencing memorandum that did not contest the facts. It contested only the framing. It described Chacona's 2-decade career, her prior service in community hospitals in eastern North Carolina, her own opioid dependency stemming from a workplace back injury, the failure of the state nursing board monitoring program to detect what was happening at the practice in 2019, and the absence of any documented patient death attributable to the tampered medication. The defense asked for a sentence at the bottom of the federal guidelines. The judge listened. The judge read both memoranda. The judge made findings on the record that the tampering had occurred over 4 months, that it had compromised the integrity of a surgical practice's controlled substance supply, that it had introduced non-sterile vials into the patient care environment, that the defendant had a prior conviction for the same essential conduct, and that the victim profile, patients undergoing surgery, unconscious or sedated, with no capacity to advocate for their own pain management, represented, in the judge's words, the most vulnerable position imaginable for any patient in any medical setting. The sentence was 48 months in federal prison, to be followed by 3 years of supervised release. The plea agreement's surrender provision was incorporated into the judgment. The North Carolina Board of Nursing was directed to receive certified notice of the conviction and to enter the permanent license surrender into its records. She was permitted to surrender voluntarily to the Federal Bureau of Prisons. She was designated to a low-security federal facility for women, where the Public Bureau of Prisons inmate locator currently lists her expected release date in late 2027. She is 45 years old. By the time she walks back out, she will be approaching 50. She will never again hold a nursing license in any state. The names of the surgical patients who underwent procedures at a Raleigh area surgical practice during the 4 months of the tampering, the patients who woke up in more pain than their charts said they should be in, the patients who were remedicated from the same compromised supply, the patients who may not yet know they were ever at risk. Those names have never been made public. They are still out there, somewhere in Wake County and the surrounding counties, going about their lives, unaware that the vials drawn during their surgeries had been hollowed out by a nurse who had been caught doing the same thing once before and given another chance and another set of keys and 78 more chances to do it again. This case was hard to sit with, but the case right here on your screen is somehow worse, and I cannot believe it is real.